Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. Dan Schatz and Tom Hill discuss stigma.
Thank you all so much for coming to this important talk. Sometimes people think of stigma as, not a big deal. Why do I have to talk about this? But in my opinion, it is the biggest deal. It's the front door that people have to come through. So without addressing stigma, we can't even get to everything else. So we have a lot to cover today. They're kind of short presentations. First, I'm going to actually talk about something called trauma, or ACEs, adverse childhood experiences. I'll hand it off to Tom to talk about social determinants, different perspectives on addiction. One of the most important things, and something we can address ourselves, is talking about stigma and language, and critically, attitudes towards medication-assisted treatment. If we have time, we have 2 cases. We'll see if we can get through 1, 2, and then see if we have time for questions and answers. So with that, I'm going to talk about ACEs, or adverse childhood experiences, or traumas. Who here, by show of hands, has heard of trauma or adverse childhood experiences? Wow, that's great. So I'm a clinician, and I ask a lot of clinical providers if they know about this. A lot of times it's less than 5% potentially know about trauma, but I'm really glad to hear that all of you know so much about it. I'd like to dig a little bit more into them. So this was a study, landmark study by CDC Kaiser Permanente in 1998. They identified 10 different traumas. As you can see here, we kind of broke them down into 3 different groups. So abuse, emotional, physical, or sexual. Household challenges, as we can understand, mother treated violently, household substance abuse, mental illness, parental separation, including incarcerated household member. And then finally, neglect, either emotional or physical. What we can see is these are really common, 10 to 25, 30% prevalence in the population. As a whole, about 50% of children experience one trauma. And notably, not only is trauma common, but it tends to come together. So if you have one trauma, you're more likely to have 2. If you have 2 traumas, you're more likely to have 3, and so on and so forth. And so the effects of trauma are wide-ranging. The most common one that we would think of is behavioral. So when individuals act out, or they feel like they need to take control, substance use, alcohol, tobacco, those kind of make sense with trauma. But we also see physical problems as well: headaches, stomach aches, heart, liver, lung. Cancer is even increased with trauma. And psychological issues, that also makes sense: depression and anxiety, PTSD, even dissociation. And finally, we also see emotional and social issues. Hyperarousal, I talk about this being a hypervigilant state. We talk about inflammation, sitting at the edge of your chair. I think the Wall Street Journal actually just came out with writing about some study that was performed, saying that our average human body temperature has dropped about 1 degree Fahrenheit, and they attributed that actually to decreased inflammation, that there's less stress. Well, you want to know who's not having less stress? These people that are, these individuals that are having trauma. And so what we think is they're kind of in a constant fight or flight action. They have to fight for themselves, and they aren't used to people going out of their ways to help them, and they're suspicious of that. So one of the most important ones, I think, is difficulty forming relationships, and that's something that we can internalize and think about ourselves. And so again, we see that this is wide-ranging. We see increases in diabetes, in cardiovascular, and that's for controlling for smoking and other cardiovascular risk factors like high cholesterol and stuff like that, and stroke. We even see rheumatological issues. So that's things like lupus is even increased with people with traumas. And specifically, since we're talking about substance use, we see a cumulative effect. So having 2 traumas is worse than 1, having 3 traumas is worse than 2, and so on and so forth. By the time you get more than 4 traumas, you have a 600% increase in the odds of problematic drinking, 550% increase in the odds of using illicit drug use. Sometimes when I talk to individuals, I'm surprised that they don't have more going on, that they don't have more substance use or more issues that have occurred when I see numbers like this. And what we see, again, on the right here, that's a percentage who have injected drugs is on the y-axis, and then on the x-axis is the cumulative trauma score. And we see this stepwise association. That really leads to more of a causation rather than an association. Okay, so we really think there is something about these traumas that are increasing the risk of drug use. And what we see is that pattern consistent with a lot of different outcomes. On the left is we see the life course of trauma. So it is experience in childhood, not up to them. We see disrupted neural development. Even on biopsies, we'll see differences. We'll see social, emotional, and cognitive impairment. Ultimately, adoption of high-risk behavioral behaviors, and disease and disability and early death. To the point that if you have 5 traumas or more, you die 20 years earlier than those with no traumas. That's devastating numbers to me. And so, again, happy to hear that many of you know about traumas here. I think we need to continue to talk and bring this to the foreground. And so here's an MRI, fMRI image of someone's brain, not to spend much time on this, but on the left is a healthy brain. On the right is someone who's been exposed to a lot of trauma. What we can see is at the top of the chart is the front of the brain. That's where executive function comes, and we see a decreased usage there. We see uptake. This is consistent with someone also who uses substances. So a lot of times substance use is a coping mechanism for the trauma. And at first it helps them deal with it, but later they become addicted and they're just trying to use that to get back to where they were before. It's kind of cumulative. And so trauma leads to a lot of senses of being blamed and judged, like it's their fault. A lot of times when I talk to, in my field, they're my patients, I try and decrease the burden on them, say, hey, of course you make your own decisions and you have some responsibility in this too, but you should recognize that there's a whole other set of factors that increase the likelihood that this might have happened. And I think that alleviates a little bit of the burden on themselves and have a framework for where this all came from. Obviously, it's criminalized, so a lot of people end up in prison or jail. Which unfortunately kind of continues the trauma. So a family who has somebody separated for substance use, now their next child is also exposed to trauma. It's pathologized. We think of them a lot of times as someone who is not normal, as opposed to an individual person who has substance use. It's patronized and isolated is a hallmark of addiction. They don't want to be exposed to everybody else. It's stigmatized, so they don't want to talk about it. And ultimately, that leads to increased death because they might be using and overdosing when someone else isn't there. So I'm going to go through these next 3 slides pretty quick, but this is some research that I did, so of course I want to put on the slides, and also has to do with what we're talking about. and also has to deal with what we're talking about. So the next 3 slides will be set up the same way. So on the left is in the adolescent, on the right is adulthood. On the top are individual traumas. In this study we looked at 9, and this is looking at a longitudinal study called Ad Health. On the bottom, we made it a cumulative score. So probably the bottom is the most important. And so what we see is that every increase in trauma leads to a 50% increase in the odds of delinquency. So two traumas, we have 50% times 50%. It's really cumulative. It's a stepwise association that we see. So this is delinquency. We think this is where it starts, then it goes to arrest. As you can see, it's a very similar pattern on that bottom, both in adolescence and in adulthood. Those numbers of odds ratios are huge. Okay, 1.7 is huge. 1.2 is, that's even big. But so this is a big association. And then again, here's for incarceration, the kind of the end point that we were looking at. So each additional trauma led to, an 80-90% increase in the odds of incarceration. So trauma is leading to a lot of this. And so what can we do? We'll kind of get to some slides very similar to this, but you need to be a champion yourself. Model what you think you should be doing, and it does spread. I start a lot of clinics where there's a lot of stigma to start, and after we address language and honesty and all these things, the stigma really decreases to the point that our front desk is making cookies and brownies for our patients as they come in. People are having Cliff Bars on hand to be able to give it to them, because how are they supposed to get their medical care if they're worried about food or worried about transportation? And make sure your relationships are authentic. If you don't know what they're saying, just ask questions. And I'll leave it at that. And so what can we do? Be aware of the association of trauma and medical conditions, as well as behavioral outcomes. Realize that this is their everyday. We get to go home. I mean, I'm not talking for any individual, but I got to go home and I get to live a comfortable life, have food, have shelter, know exactly what my next day is going to be. That's not the same for a lot of these patients. And so they might think that they have to act out. They're going to have difficulty with trust. So when you form a relationship with them, first of all, recognize that it's going to take a little bit of time to do that. And then also recognize that if there's a slight misstep, they might jump back, okay? And you might need to take time to build that trust back up. And so be patient with them. And with that, I'll pass it off.
So I'm going to take over. Thank you, Dan. I want to share something with you. I am a person in long-term recovery from addiction. So for me, that means I haven't used alcohol or any other drug since 1992. And so when, you can clap, it's okay. But I didn't do it for the applause. When I got into recovery in 1992, I didn't have a trauma framework. I didn't even know that word. And the ACEs study hadn't happened yet. And I've shared with some of my other colleagues, it's like, I have a 7 on the ACEs score. And so when I learned that framework, a lot of things that had been floating around, even in my recovery work that I didn't have a place for, all fell into place and made a whole lot of sense to me. So that framework sort of alleviated. It didn't take away my personal responsibility, but it made my addiction made sense. And I knew it wasn't my fault, because there was always this thing, and people will say, well, I didn't put a needle in your arm. And that's a common attitude, right? So it's like, no, you didn't, but I never went out of my way to become addicted either. It wasn't in my game plan. It's something that happened. I still have to take responsibility for it, but it happened. So I think the flip side of stigma, and when we talk about stigma, we always talk about discrimination, but the flip side is shame, because that's how we internalize it. And that can be such a barrier for asking for help or getting for help, as Dan just said in that last slide. I want to talk a little bit. People are aware of the social determinants of health? So some, but not a lot. Again, that would have been a framework that would have been helpful for me also. And I think it's helpful for all of us to look at the social determinants of health as something we all sort of see every day, see aspects of every day. But when you add these various effects with trauma effects, it's really compounded in terms of barriers to healthcare and the healthcare system. So where you were born, what kind of family you were born into, what kind of access to healthy food you've had, what kind of housing, where the housing is, what kind of education you've had, did you go to good schools, did you go to bad schools, did you go to schools at all, did you drop out? Like all of these things sort of build up into a composite of either healthy behaviors or sometimes unhealthy behaviors. And it's a very a handy reference to have in terms of, we know that many people who fall under social determinants of health have been denied access or not gained access to the kind of health care that we all deserve and need. And then the whole idea of health equity. So this picture, it's pretty common right now, but we've always talked about equality as opposed to equity. And in equity, everybody's boosted up so they get to see the same ball game, as opposed to equality where everybody gets the same step. So it's a different paradigm to sort of view in terms of helping, like who needs to get boosted up, who has low social determinants of health that need to be addressed in terms of how we're going to help people get better. And that's the goal. So Are folks aware of the Surgeon General's report from 2016, Facing Addiction in America? Groundbreaking report, the first ever about addiction. The slide drops off, but it defines addiction as a well-supported scientific evidence shows that addiction to alcohol or drugs is a chronic brain disease that has potential for recurrence and recovery. Recurrence is another word for relapse. Or return to use, but it also embeds recovery into that definition. The recovery is possible and even an expectation. But it also, it breaks things down. So it moves addiction from the idea of a moral failing to a brain disorder, big shift. From the highest ranking surgeon in the land saying this, moving from a chronic to an acute to a chronic condition. So that's addiction was always treated as an acute condition. We know now that that was probably not a good idea because it's a chronic condition and needs to be treated as such. Moving to public health strategies, dropping old stigmatizing language, we're going to talk about that in a minute, and developing new terminology, and developing science that informs policy and practice. So often in certain communities, I'll talk to people and they'll say, well, I don't believe in medication. And it's like, well, it's not something you believe in or don't believe in. It's science. Like, you can't not believe in science. This is a really good seminal report for that. So besides that a definition, other people have been weighing in with a slightly different perspective, but I think still talking about that chronic condition. Sally Satel says, she's a psychiatrist, says people discover that opioids are an excellent short-term balm for existential maladies like self-loathing, emptiness, erosion of purpose, and isolation. All things we talked about with the ACEs scores. Years of heavy use condition people to desire drugs as the first stab of distress. After so much time spent damaging themselves, their families, and their futures, a new layer of anguish has formed over the original bedrock of misery, urging onward the cycle of misery and relief. Surely people don't choose to be addicts, but that's not what they are choosing. What they want is relief. Does that make sense to folks? Gabor Mate says that any behavior associated with craving and temporary relief and long-term negative consequences, which don't matter when you're in the throes of addiction, the long-term consequences, negative or positive, are meaningless, and that the person is not able to give up. And that people use substances to self-medicate to soothe their emotional pain. But more than that, their brain development was sabotaged by their traumatic experience. So remember Dan showed that picture of the brain, before and after, or the healthy brain and the traumatic brain. There's pictures of the addicted brain the same way. So we're talking about actual brain chemistry changes that happen both as a result of trauma and as a result of repeated substance use. And then finally, Dr. Vincent Folletti, who oversaw the ACEs study, says the current concept of addiction is ill-founded. Our study of the relationship of adverse childhood experiences to adult health status in over 17,000 persons shows addiction to be a readily understandable, although largely unconscious attempt to gain relief from well-concealed prior life traumas by using psychoactive materials. So these three experts are sort of dissecting this idea and really presenting a paradigm shift. So that when you have this information, it's very difficult to talk about personal blame or shame or all those things. It's very difficult to point fingers when we have some scientific evidence that shows how this happens in people's experience and in people's brains. So we're going to talk about language very briefly. We could do a whole day workshop on this. And people always sort of roll their eyes and say, it doesn't matter what we say. And I say it really does matter what we say and how we say it. Because as our thinking evolves, our language needs to evolve with it. And if we're using old language to convey new thoughts, it ain't going to work. So William White, who's an addiction treatment historian, says that for 2 centuries, addicted and recovering people in America have been the object of language created by others. And Don Coyas, who is the founder of White Bison, which is a Native American recovery organization, says words are important. If you want to care for something, call it a flower. If you want to kill something, call it a weed. So this is a chart, and this chart is out there in the public lexicon. It's in various forms right now, and it's really, really helpful because what we're talking about is going to person-first language. So, and this is nuanced, right? So, first of all, the word abuse has got to go away. We've been talking about this for 20 years. Everyone still lets it slip into their vocabulary. Our institutions have that embedded in the names, and it's a problem. Because abuse, if we go back to the ACEs study, what does that word mean? And what does that word mean for people who have been abused as part of their trauma and now are called abusers? Not really a good use of language there, right? And if we're trying to pull out the negativity aspects of being addicted to alcohol or other drugs, the word abuse is not only not very accurate, but it's also damaging. So think about that. And the other, so we say people with substance use disorders, people in recovery, people with justice involvement as opposed to criminal, felon, convict, offender, I hear a lot. And I know those are words you use a lot, but I'm asking you not to not use them, but to start thinking about when you use them, what kinds of meanings they're conveying when you call somebody an offender, right? Because you're not talking about a person who did something, you're labeling them with an idea that is not something that they created for themselves. Another thing I hear a lot is clean and dirty urinalysis. And it's so easy to say positive or negative, but we're so used to saying clean and dirty. But when we call something dirty, what are we saying? And so I think just thinking, it's like taking a moment to think about the words we use, and are they damaging or are they life-fulfilling is a good barometer to think about when we're using language. So as we're moving away from this idea of blame and shame and moral failures and bad people, we need to sort of have a language that reflects. Does that make sense to folks? And you know how difficult that is, right? You know how difficult it is to change that we're talking about a culture shift here. And it's with the public, it's with the media, but it's also in our professional roles. The other thing about this is, a lot of times people who are using drugs or people in recovery will refer to themselves as an addict or a junkie, and that's okay because they're naming themselves. But as professionals, it's our job to role model the kind of language that we want them to reflect upon. So we don't need to correct their language, but we can role model it in a way that's more positive and that they can possibly pick up on. So this whole idea about stigmatizing addiction, as we know, carries over to medication, right? And I'm going to say it out loud so we can all hear it. It all goes back to methadone. It's years and decades about methadone, and it's largely based on myth, and it's largely based on superstition, but it is out there. So, and buprenorphine sort of came in close behind because it's a partial agonist, both because they're opioid-based, right? So because of that, people have sort of taken that idea and run with it over the years. And so the beliefs are held by practitioner, recovery community members, the general public, that medication-assisted treatment we call it drug replacement therapy. We also call it substitution therapy. So when we say drug replacement, we're basically saying that you're taking, not a medication, you're taking one drug and substituting it for another. But this is like official language that we use. We talk about it as a crutch. We say you're getting high, you're cheating recovery, and we say that it's not abstinence-based, and I'm going to take some issue with that in a minute too. So you all are familiar with all this, right? But that's what we're up against. And we're trying to sort of pull people on board with what we're doing. This is a culture shift. So the good news is that things are changing. And even in the past 5 years, things have changed enormously. And I will just point out too, in this list, a lot in the recovery community, and I think through the field, a lot of it is 12-step based. Now, I've been practicing 12 steps for 27 years, so I'm not bashing the 12 steps, but I know that it's not for everybody. But I also know that Narcotics Anonymous does not take a great view on medication and has treated people on medication as second-class citizens. You can come, don't talk, don't share, and you're not allowed to take leadership positions. So what does that mean for somebody coming in those doors? Is that welcoming? Absolutely not. And those attitudes have prevailed over the years, sometimes more hostilely than others, but it's always an undercurrent. And I don't know that that's ever going to change. But there are alternatives to 12 steps that people can access now. I will also say that for people, like I know people on methadone for years who have experience stigma and discrimination on every level. So they internalize that. They don't share it. They don't tell their families. They don't tell people at work. It becomes a secret. And we know that secrets are not the best thing to be holding in recovery. But they've been denied access to the recovery community as well. So that needs to be addressed. So one thing that we've thought about a lot is we hear people saying medication versus abstinence-based recovery. And I think that what we've come up with is a term called medication-assisted recovery, MAR, as opposed to MAT. And it emphasizes a commitment to engaging in recovery supports to achieve long-term abstinence-based recovery while using medication. So what I always say is you're using methadone or buprenorphine on doctor's orders, doctor prescribed, doctor dosed. You're not using opioids. You're not smoking pot, you're not drinking, you're not using methamphetamine, you're not using any mind-altering substance. You are practicing abstinence-based recovery. And I think we need to start using that language because we confuse people otherwise, and we do ourselves a disservice by pitting these two polarities against one another that are not mutually exclusive. Because you can be on methadone or buprenorphine or Suboxone and still practice abstinence-based recovery. Do you hear what I'm saying here? Do you believe that? I believe it, and I've witnessed it over and over and over again. The other thing is this conference is called Medication for Opioid Use Disorder because a lot of folks think that MAT is now stigmatized. So as our thinking has evolved, we're trying out new language in that area as well. And where did I put that? Is it time?
What time did we go till?
Yes, it is.
10 minutes, great. So I wanted to talk about one of the most common pushbacks is this really trading one drug for another. I take care of hundreds of patients, and the first time I see them, I start talking about this. It's not changing it. One is you're getting it from a provider saying, hey, here you go, here's the prescription, you get it for this amount of time, we make sure it's safe, we're going to track how you're doing. But also, they don't feel high at points, they just feel normal. I also have a lot of residents who rotate with me, and so I have the patients tell me, hey, do you feel high when you take Suboxone or buprenorphine? And they say, no. They all say, no, I just feel normal, I can go about my day. There was one patient, though, who said, you know what? I get high on life again, and they're saying, I hear the birds chirping, the walk is more enjoyable, food tastes better, I have fun going out and playing basketball. The other things is my patients who have been in long-term treatment, a lot of them get employment. That's my favorite part of this, of treating substance use, is the relationships start improving. They reconnect to the people. And they're not getting incarcerated or going to prison as much. It's a treatment versus an all-encompassing addiction. So to say that those two are the same, it doesn't compute to me. It's not the same thing. They're completely different. The other thing I say is that this is really, the day that someone comes into my clinic to get treatment is the day they start talking about, hey, when can I come off of this? I don't want to have this crutch. I want to be able to do it myself. And so I tell them, long-term studies are always difficult to come by, but someone with opioid use disorder who's been on medication-assisted treatment, MOUD, let's go with that.
Medication for
assisted
opioid use disorders.
Yeah, medication
Not
for
assisted anything. Yeah.
But if they stop buprenorphine, 90% will relapse by 1 year. Now, I'm not sure if that's the exact number, but the point is that there's a very high rate of relapse. So I let them know that, and not that everyone falls into that 90%. Some people might fall into the 10%.
I also just want to add that I think, a lot of times the attitude was medication is okay as long as you taper off. And the studies show that that's not true.
Right.
And so, this idea that but you need to taper off within 3 months, you would never ask anybody to taper off any other kind of medication.
Exactly. And there's more and more studies. So someone who tapers off, no matter if they've been taking it for a year, 2 years, 3 years, 5 years, there's about a 5% overdose rate in the following year after they stop, no matter where they are in their recovery. It's not a moral failure. Just like any treatment, it's always a combination of medications and behavioral changes. I use diabetes a lot. Once you're on insulin for diabetes, it's tough to come off. It's not impossible, but it's tough to come off. But also, it would be malpractice just to say, here's your insulin and you're done. No, you have to do exercise and diet. And likewise, it'd be malpractice to just say, hey, do exercise and diet, and they'll take care of your uncontrolled diabetes. It's a medication and behavioral treatment, and it's that combination. So when I give treatment, I also say, hey, it's important to be addressing some of the other issues in your life as well. Hopefully this is kind of beaten down throughout this conference, but any transition is very difficult. Once someone's incarcerated and they leave the prison system, the rate of overdose is extremely high in that first 1 to 2 weeks. So this is a really important part to continue treatment while incarcerated. It reduces the mortality rate by 75%, and it also reduces recidivism as well. And so I think this is our final slide besides the cases, which we could do. Questions or cases, we'll decide in a second. But I want to leave you with, stigma is not just some theoretical issue. It really has impact. So because they're stigmatized, a lot of times they won't seek care. They say, I got to deal with this myself. So they never come to my clinic to start with. They don't follow up with care. They say, hey, I'll start this and just give me a couple weeks of time without substances and then I'll be fine. And so they won't follow up. They'll stop treatment early. They use alone, so if they overdose, no one's there to give them Narcan. They lose their support system because they're embarrassed to talk to people, or people don't quite understand that this is not something that they're wanting to do. Housing, employment, and education, legal issues, loss of self-efficacy. Delayed care is another common one. Someone might need surgery, but if they're using any drugs, the surgeon might deny them care until they show 6 months of abstinence. So all those things really play a part of how stigma impacts the actual individual. Do you want to do cases or questions?
Do the second case.
Okay.
Yeah.
I'll do one of the two cases. So this is a patient who just recently came to me. He's in his early 20s, and he came into the emergency department in opioid withdrawal. He's been taking oxycodone. He had a dental issue, got oxycodone, and needed escalating doses. He was seen in the emergency department. In all of our emergency departments, we have peers and social workers who will kind of do the initial engagement. And luckily, they introduced the idea of MOUD, so we'll have to change that. The patient accepted, and we give them Suboxone right there, so they have a positive experience of it. And they followed up with me in primary care. At follow-up, he was still using oxycodone in addition to Suboxone, so he was only taking 4 milligrams, which is a very low dose. Most of my patients are at 16 to 24. And so what I did is I explained all the stuff that we talked about. His mother was there, actually, and we increased the dose. He was actually in withdrawal when I saw him. He was anxious, kind of moving forward. It's hard to even have a full conversation when someone's in the throes of withdrawal. At the second visit, this patient felt so much better. He was smiling, he was bright, he's a very charismatic kid or person. He had already finished high school and was looking for a job. He was so excited to see me. He played basketball, which I happen to like, so we connected on that. And at the third visit, he actually let me know that his mother has a substance use, that she's been drinking, she's been able to avoid alcohol for a number of months, so on her way towards long-term recovery. But he also mentioned that he has a younger brother who's about 10 years old, who he came home and saw that his mother had passed out and was in her vomit. And the younger brother saw that. And that was actually an impetus for him to get into recovery and start treating, because he knew that he had to be there for his younger brother. He's now telling his friends and family all about Suboxone, so he's actually recruited more people. The thing that I want to highlight is how this kind of goes from one generation to the other. The mother was using alcohol, so that increases the risk. Separated family as well increases the risk of substance use in my patient's life. But then also now the younger brother is at high risk. But having a positive mentor like an older brother is astronomically important for that child. So getting treatment is helping multiple people in this case.
Go ahead,
do the other one. Okay, wow, how lucky. I love cases. I think it's the most important thing when we see patients and hear about them. They really kind of highlight it. And it spans a whole wide range. I've taken care of 20-year-olds to 80-year-olds for substance use, alcohol and opioids. This was a 40-year-old man who had a history of abusive parents, parental separation, substance use, financial insecurity, and witness violence. And has a history of PTSD. Started using IV heroin use, and ultimately he was employed for a while, but then still couldn't afford his substance use, so started shoplifting to afford his addiction. He was started on Suboxone. So at Rikers, we have a program called KEEP, which is really great, and it starts people who have opioid use disorder on Suboxone or methadone, and had a direct handoff, a warm handoff to primary care. We get a call, and he came and saw us and continued getting medication-assisted treatment. He did well with us for over a year, maybe even 2 years, but then he was going to NA, as Tom mentioned, and a friend told him, "You're actually not truly cured or clean unless you stop all substance use, including Suboxone." He didn't tell us that, and ultimately stopped and didn't come back to clinic. Years later, though, he came back to clinic. His asthma had gotten worse, his medical conditions had gotten worse, and had relapsed, and actually had another stint in prison for a short bit. And he was reintroduced on Suboxone. He's doing much better with his opioid use, but now he's having to recover again with the family strains who thinks, oh, this is just another cycle, we're just going to keep going through this. Because of this case and a number of other ones, I actually talk about this with my patients or individuals right away, saying, hey, there's people out there that believe this, but this medication is a relationship between me and you, and so if you do want to try and come off of it, please communicate with me. We'll talk about it, we'll take it slow, we're going to have increased observation, and I'm going to let you know the whole way that it's a risky decision. But that's our second case.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.